students, let's start with our today's session, that is on anti-hypertensive drugs. So first of all, explaining you etiology of hypertension. What is hypertension? Hypertension, you can say that there is rise in blood pressure which is said to have hypertension, right? Now, patients is classified according to two type of hypertension, that is based on essential or primary hypertension, and second, that is secondary hypertension. In essential or primary hypertension, there is no specific cause, right, for hypertension, right? But in secondary hypertension, the patients have specific etiology, right? Say some have diabetes, some have stress, right, for occurring hypertension, that is said to have secondary hypertension, right? You can say genetic factors, say physiological stress, environmental and dietary factors, all these are contributing to development of hypertension. Okay. The next is classification of hypertension on the basis of blood pressure. As you know, that the normal blood pressure of any human being is 120 by 80, or 120 is to 80, you can say, right, mm of Hg. Now, pre-hypertension, which means when there is slight increase in the level of systolic blood pressure and diastolic blood pressure, that is say 120 to 135 systolic and 80 to 89 diastolic blood pressure. Then hypertension, right? You can say when the hypertension, or when the blood pressure is greater than or equal to 140 by 90, then stage 1 hypertension and stage 2 hypertension. Stage 1 hypertension, that is 140 to 159 systolic blood pressure and 90 to 99 diastolic blood pressure. Then greater than or equal to 160 by 100, right, that is said to have stage 2 hypertension. Now stage 2 hypertension is also called as emergency hypertensive condition, right, which means a patient needs quick emergency or appropriate treatment immediately, right? Now, how blood pressure is maintained? So it is maintained by arterioles, post-capillary venules, that is capacitance vessels, heart, kidneys are also playing for maintaining blood pressure. Then baroreflexes in the body, which is maintained by autonomic nerves, right? It includes a combination with humoral mechanisms including renin, angiotensin, aldosterone system. You can say RAAS, that is RAS, right? Then local release of vasoactive substances. Now, hypertension has occurred. Now, how to cure hypertension? So, which are the agents, or what is the treatment required to cure hypertension? So, anti-hypertensive agents, which is our today's topic, right? So, you can classify as A, B, C, D, E. You can remember this, right? So, first A, that is ACE inhibitors or angiotensin receptor blockers, right? Then B, that is beta adrenergic blockers, right? Then C, that is calcium channel blockers. D, that is direct renin inhibitor or diuretics. You can remember this as A, B, C, D, E. Okay. Then beta and alpha adrenergic blockers, then alpha adrenergic blockers, then central sympatholytics, vasodilators, right? And some others, for example, adrenergic neuron blockers, ganglion blockers, they are also acting as anti-hypertensive agents. So starting with diuretics, that is thiazide type of diuretics. For example, hydrochlorothiazide, chlorothalidone, they lower blood pressure initially by increasing sodium and water excretion, right? They can induce hypokalemia, hyperuricemia, and to a lesser extent, hyperglycemic condition. As I've told that the mechanism I explained, so reducing sodium and water retention, it reduces blood volume, which reduces cardiac output, which reduces peripheral resistance also, and which causes decrease in blood pressure. Then the next is loop diuretics. Loop diuretics, they are inhibitors of epithelial sodium transport at late distal and collecting ducts, right? For example, furosemide, ethacrynic acid, right? Or you can say they are antagonizing aldosterone receptor. For example, spironolactone, eplerenone, and reduce potassium loss in the urine. This aldosterone antagonist have additional benefit of diminishing cardiac remodeling that occurs in heart failure. The next is loop diuretics. Loop diuretics, they act promptly by blocking sodium and chloride reabsorption in kidneys, even in patients with poor renal function and those who are not responded to thiazide diuretics. Loop diuretics cause decreased renal vascular resistance and increased renal blood flow. Then potassium sparing diuretics. So potassium sparing diuretics, for example, spironolactone, eplerenone are competitive antagonists that either compete with aldosterone and directly block epithelial sodium channel. Now, ACE inhibitors, always when there is lower blood pressure, right? So there is a body mechanism that kidney start releases renin, right? And this renin, it gets converted into angiotensinogen, which further gets converted into angiotensin 1 and angiotensin 2. Now from angiotensin 1 to angiotensin 2, it is converted in the presence of angiotensin converting enzyme that is called as ACE, right? Now what is the effect of this, right? So this ACE inhibitors, they are blocking conversion of angiotensin 1 to angiotensin 2, right, which causes a regulation of blood pressure, and renin inhibitors, they are also used, right? So ACE inhibitors, they are recommended as first line treatment of hypertension in patients with a variety of compelling indications, right, including high coronary disease with risk or history of diabetes, then stroke, heart failure, myocardial ischemia, or chronic kidney disease. Then ACE inhibitors, they are responsible for breakdown of bradykinin, a peptide that increases production of nitric oxide and prostacyclin by the blood vessels, right? And this nitric oxide and prostacyclin, they are potent vasodilators. Now, so what this ACE inhibitors does, it decrease angiotensin 2 and increase bradykinin levels, right? As a result, vasodilatation is decreased, right? Is a result of decreased vasoconstriction, right, from diminished levels of angiotensin 2 and enhanced vasodilatation. So it increases the process of vasodilatation by increasing bradykinin, right? So by reducing circulating angiotensin 2 levels, ACE inhibitors, they also decrease the secretion of aldosterone, resulting in decreased sodium and water retention, right? This ACE inhibitors reduce both cardiac preload and afterload, thereby decreasing cardiac work. Then adverse effects of ACE inhibitors, it causes hypotension, right, that is sudden fall in blood pressure, hyperkalemia, cough, rashes, urticaria, angioedema. Then further adverse effects are fetopathic headache, dizziness, nausea, bowel upset, granulocytopenia and proteinuria, right, acute renal failure. Then advantages of ACE inhibitors is that free of postural hypotension, electrolyte disturbances, and feeling of weakness and CNS effects. Then it is safer in asthmatic patients, diabetes, and peripheral vascular disease patients. Then long-term ACE inhibitor therapy has a potential to reduce incidence of type 2 diabetes in high-risk subjects. Then no rebound hypertension or withdrawal is found. Then further advantages is that no hyperuricemia, no deleterious effects on plasma lipid profile. Then ACE inhibitors are most effective drugs for preventing sudden cardiac death in post-infarction patients. They are less effective for primary prophylaxis of myocardial infarction and preventing left ventricular hypertrophy. Then the uses is that it is used as a first-line drug in all grades of hypertension, right? Then essential hypertension respond to monotherapy with ACE inhibitors, right? Then in congestive heart failure, it is also used. It causes both arterial and venodilatation, reduce afterload as well as preload. Then in myocardial infarction, long-term ACE inhibitor reduces recurrent myocardial infarction. Then prophylaxis in high cardiovascular risk subjects. So they are protective in, it is also used in that in patients with left ventricular dysfunction, right? Then they improve endothelial function also. Then the next is uses of ACE inhibitors, right? That is, they are also used in patients with diabetic neuropathy, right? Then non-diabetic neuropathy, right? And scleroderma crisis. In diabetic neuropathy, prolonged ACE inhibitor therapy has been found to prevent or delay end renal stage disease in type 1 as well as in type 2 diabetes. In non-diabetic neuropathy, ACE inhibitors reduces proteinuria by decreasing pressure gradient across glomerular capillaries as well as by altering membrane permeability. Then in scleroderma crisis, the marked rise in blood pressure and deterioration of renal function in scleroderma crisis is mediated by angiotensin 2. ACE inhibitors produce improvement and are life-saving in this condition. Then next is angiotensin receptor blockers. For example, losartan, candesartan, valsartan, telmisartan, olmesartan, irbesartan. All the sartans, they are angiotensin receptor blockers. They produce arteriolar and venous dilatation and block aldosterone secretion, thus lowering blood pressure and decreases salt and water retention. They do not increase bradykinin levels. They are first-line agents for treatment of hypertension, especially in patients with a compelling indication of diabetes, heart failure, and chronic heart disease. The next is direct renin inhibitor, right? As I've told that kidney releases renin when there is sudden fall in blood pressure to balance the blood pressure decrease, right? So renin, and this causes salt and water retention, right? So renin inhibitor is used, direct renin inhibitor, for example, L-skyrine, right? It is used, but the adverse effect is that it causes diarrhea, especially at higher doses, and it also causes cough and angioedema, right? So it is probably less used than ACE inhibitors. It is contraindicated also during pregnancy. The next is beta adrenergic blockers. They are mild antihypertensive and do not significantly lower blood pressure in normotensives, right? So in stage 1 cases of hypertension, beta adrenergic blockers, they are used alone. The next is beta adrenergic blockers, in that propranolol, right? Propranolol is first beta blocker which is effective in hypertension and ischemic heart disease, right? Then it has replaced largely to metoprolol and atenolol nowadays, right? It is useful in lowering blood pressure in mild to moderate hypertension, right? But the adverse effect is that it causes reflex tachycardia. Then metoprolol and atenolol, they are cardioselective, right? Which are widely used beta blockers in treatment of hypertension. It is used in inhibiting stimulation of beta-1 adrenoreceptors. Then sustained release of metoprolol is effective in reducing mortality from heart failure, and it is particularly useful in patients with hypertension and heart failure. Atenolol is reported less effective as compared to metoprolol nowadays. Then other beta blockers are nadolol, cartiolol, non-selective beta blocker antagonist, then bisoprolol, bitoxolol, right? Pindolol, ace-butalol, penbutalol. All these are partial antagonists, that is beta blocks with some intrinsic sympathomimetic activity. They are particularly useful in patients with bradyarrhythmias or peripheral vascular disease. Then other beta blockers are labetalol, carvedilol, nebivolol. They have beta blocking and vasodilating effects. Esmolol is selective beta-1 selective blocker, right? It is used in management of intraoperative and postoperative hypertension. The next is alpha adrenergic blockers, that is prazosin, terazosin, doxazine. Prazosin is a prototype of alpha-1 adrenergic blocking agent, right? This alpha blockers reduce arterial pressure by dilating both resistance and capacitance vessels. Then other alpha adrenergic blocking agents are phentolamine, phenoxybenzamine, right, which are useful in diagnosis and treatment of pheochromocytoma. The next is clonidine, that is centrally acting adrenergic agents, right? They are centrally act as alpha-2 agonists to produce inhibition of sympathetic vasomotor centers, decreasing sympathetic outflow to the periphery, which this reduces total peripheral resistance and decreased blood pressure, right? It is used in a combination with diuretic at present. Then next is methyl dopa, which is alpha-2 agonist, right? It is used in hypertension in pregnancy. The next is vasodilators, that is hydralazine, dihydrolazine and minoxidil, right? They are used to treat hypertension. Hydralazine is an accepted medication for controlling blood pressure in pregnancy also, right? Pregnancy-induced hypertension. Now, all these agents, they produce reflex stimulation of heart, resulting in competing reflexes of increased myocardial contractility, heart rate and oxygen consumption. Right? These vasodilators, they act by producing relaxation of vascular smooth muscle, primarily in arteries and arterioles, which results in decreased peripheral resistance. Now the treatment agenda or of hypertension, right? For hypertensive emergency, when it occurs when the blood pressure is more than 180 mmHg, that is systolic blood pressure, and diastolic blood pressure, it is more than 120 mmHg, right? Which provokes a situation of any organ damage, right? Target organ damage, and which results in stroke. For example, if it damages brain, then myocardial infarction. So in this, the treatment is that it uses calcium channel blockers, right? Then nitric oxide vasodilators, then adrenergic receptor antagonist, then vasodilator, hydralazine, dopamine antagonist, all these are used. Now, resistant hypertension, right? Which means it is defined as blood pressure that remains elevated despite administration of optimal 3-drug regimen, right? Which includes a diuretic also. So the common cause of resistant hypertension is that it causes poor compliance, excessive ethanol intake, concomitant conditions like diabetes, obesity, sleep apnea, hyperaldosteronism, then high salt intake, metabolic syndrome, right? Then insufficient dose or drug. So the treatment of hypertension, it is summarized that it is follow ABCD rule. That is A for ACE inhibitor or an angiotensin receptor blocker, B that is beta blocker, C that is calcium channel blocker, and D that is diuretic, right? Now, these are the complications which can occur due to hypertension. For example, brain stroke, vision loss, heart attack, bone loss, kidney failure, or bone blood vessel damage. All these are the complications which can occur. These are the references, students, for this session, and these are the frequently asked questions. So, for more such e-lectures and e-videos, please like and subscribe our YouTube channel, Pharma Ignite. Thank you.